Hi everyone, my name's Cheryl Hoffman and I'm from UCLA. I'm specifically from the Department of Interventional Radiology, and I want to thank everyone for asking me to be here today. I'm very excited to speak with you about varicose veins, varicocele, and pelvic venous congestion. So varicose veins are big refluxing veins, and I hope by the time that we're done here it'll become really clear to you what they look like, how we treat them, and what we can do to make things better. Varicoceles are sort of the male version. Large dilated veins, refluxing veins around the scrotum and testicle, and pelvic venous congestion can be the same thing in women, in the pelvis and around the perineal region. So I'll be putting these together for you, describing this entity, and hopefully by the end you will have a clear picture of what refluxing veins, abnormal refluxing veins, are like and how they present in our bodies. And of course at the end we'll leave time for plenty of questions, okay? So here we go. We'll start with the first one, varicose veins. These are so common, I'm sure you've seen them around. Here we are in Southern California, everybody's wearing shorts. And this is a classic example. You can see these large ropey veins on the inner aspect of the calf, and these are very classic and very common. You have a long vein that runs from the groin all the way down to the ankle. It's called the great saphenous vein. And though you don't see it typically, unless you're a marathon runner with no fat, then you can sometimes see this long straight vein. All of us have that vein. And when it is not working properly, when it is dilated and the valves aren't working well, it can become twisted and give off these large varicose veins. So the great saphenous vein I like to describe as the trunk of the tree. This is the trunk of the tree, and the varicose veins are the branches, the abnormal little offshoots of the river, if you will, that are abnormal, and those are the ones oftentimes that we see. So here's an example. Here's a normal vein. It's small, and there's nice valves. Remember, your heart pumps and arterial blood goes to your toe with the oxygen, and after your tissues have been oxygenated, they have to come back to your heart. So they have to fight against gravity. And as you walk, the calf contracts, the blood is pushed up, and the valves have to close so the blood does not go in the wrong direction. But when you have a dilated abnormal varicose vein or great saphenous vein, this vein becomes dilated and the valves no longer close and the blood glues in the wrong direction. And here you can see on the inside of the knee and the calf these abnormal dilated veins like so. And here is the human example beyond the drawing, showing you a dilated varicose vein, but it is coming from an abnormal great saphenous vein. Now, we have other ways of knowing that our great saphenous vein, that large trunk vein or the big river, if you will, is abnormal. It doesn't always present with the dilated varicose veins. Sometimes if you look around the inside of your ankle, you can see all this blue discoloration and small abnormal veins in this area. Or if it really is bad and we don't want to get to this point, you can actually even get an ulcer, an oozing, awful, and very painful ulcer that would occur in the distribution of the great saphenous vein. And they occur low because the blood by gravity has been pushed to the bottom. There's too much blood in this area and the body is reacting in an inflammatory way. And you have breakdown of the skin, a weepy, painful ulcer, and we do not want to get to that point. We want to take care of the problem way before we get to this point. But these are other ways that you can know that you have, or someone in your family, some friend, etc., has great saphenous vein reflux and abnormality to the superficial vein system. Now that is in contrast to the deep veins. The deep veins we want to keep open and we worry about blood clots, right? Deep vein thrombosis, those are very serious. Those are very different veins than what I'm describing here. The deep veins carry 95% of your blood. These superficial veins only carry about 5% of your blood, but when they're not working well and they're big and refluxing, dilated, they can cause a lot of problems, which I'm showing you here. So here's an example of some varicose veins in the front, but also in the back of the leg, as you can see in this region. So when we have varicose veins in the back of this leg, we have to wonder about the small saphenous vein, and that's a refluxing superficial vein that runs behind the calf. And when that vein is abnormal as well, that's another trunk of the tree, if you will, or a large main river. And the varicose veins tend to be the abnormal tributaries, the abnormal branches of the trunk, the tree trunk, or branches of the river. This vein we can treat, we can close, and I will show you how we do that. But I want you to understand that the great saphenous vein, that long one on the inside of the leg, or the small saphenous vein which runs behind the calf, are the two main superficial veins that can be causing so much of this havoc. So varicose veins and venous insufficiency are extremely common. Women more than men, but in both, of course. About 25% of women and 15% of men, but some people say up to 40%. You know, the data varies, but you can kind of understand that about 25% of women and 15% of men are affected. Now, if you have one parent that has this abnormality, it goes up even higher. In women, up to maybe 60%. And if both parents have it, 90%. So it's incredibly common. Heredity is the #1 cause. People ask me, is it because I'm standing all day, or, you know, my work, or I got hit by a ball? You know, I hear all sorts of things. And though some things can make it worse, the #1 factor that really makes it occur is your genes, heredity. Other contributing factors are pregnancy, obesity, older age, prolonged standing, and lack of movement. I'll explain in a moment, but when your calf contracts, you really push that venous blood up to your heart. So walking a lot is extremely important for the health of your veins. In pregnancy, varicose veins and venous insufficiency is more common. There's more pressure on the belly, more pressure on some of those veins. And you'll see you can also get vaginal varicoceles if you're a woman in particular. These are the causes of a variety of abnormal veins, refluxing abnormal veins. More symptoms of venous disease. How do you know you have the problem? Of course, if you see those dilated veins that are wiggling, or the abnormal blue discoloration on the inside of your ankle, as I showed you. However, also, what if you have swelling, for example? That can be caused by these abnormal veins. Heaviness in your legs, particularly at the end of the day, that can be caused by abnormal superficial venous disease. Cramping. How about restless leg syndrome? These are all associated with abnormal venous disease. And if you have any of these things, you need to think, could I have a problem with my veins? Itching and rashes. They too can be caused by having too much blood in your legs and just being uncomfortable and having more of a sense that you want to itch your legs. So I just talked about the importance of this calf muscle pump. It is incredibly important that we all walk and contract the calf so the venous blood can be pushed back to the heart. It's important when we have healthy veins, and it's also important when we do not have healthy veins. What we want is this superficial blood to be pushed towards the deep veins and then up to our heart. If there's reflux, the blood goes in the other direction. It goes from the deep vein out to the skin towards the varicose veins. So varicose veins are bigger veins, usually greater than 4 millimeters. Reticular veins are a little smaller, more in the 2 to 3 millimeter range, and they can be blue. And spider veins, or telangiectasias, are about 1 millimeter, and they can be blue or red as well. So typically, when you have these sorts of veins, these smaller veins, there's an underlying cause. And as I showed you here, you see how it goes in the wrong direction? These are the spider veins, but they go to a reticular vein, and eventually they can communicate with abnormal varicose veins. And you know, the whole system, it's the inside of the system that frequently is abnormal, and we're just seeing the abnormal veins on the very outside of the leg. So how do we figure out what the problem is? Well, we start with a medical history, of course, asking all those different questions about symptoms. We do a physical exam. We look at the legs. Are they swollen? Do you have a rash? Do you have any varicosities, reticular veins? We do a duplex ultrasound. And occasionally, if it's only left-sided, we worry about a problem up in the pelvis. Are things sort of being congested because one of the main veins in the pelvis is abnormal? And if that's the case, we'll do an MR venogram of the pelvis. But here's a copy of our intake form. And again, like those symptoms I shared with you, here's a long list of all the things that can be symptoms. It includes how many times do you feel like you want to sit and elevate your legs. If it's 2 to 3 times a day, that's not normal. Most people, if you remember when you were a different age or before this was a problem, you didn't have that feeling. So if you feel like you need to take a break and elevate your legs a few times a day, or at the end of the evening you really need to get your legs up, that can be a sign that you have the problem as well. This is a copy of our ultrasound reports, and you can see that we make it very simple. We really draw things out. Our wonderful technologists are so patient and detail-oriented. They do just a beautiful, beautiful job. And we draw out the veins that are refluxing, the varicose veins, the aneurysmal part of the veins. So there's really a map. And when you come to see us, we can show you that map so it becomes really apparent when we look at your legs and when we look at our drawing what the problem is. We also record how much reflux is happening. Is it just a little bit or is it a lot? Those things are extremely important when we try to figure out what to do. Here's a clinical severity score, and this basically says, in the afternoon, do you have swelling, but now when I see you, do you not? We give you a grade that's a clinical grade, and we also do give you a physical grade. Do you have varicose veins? Do you have swelling? Do you have skin changes? Do you have an ulceration when I'm looking at you in the clinic? And we map that out, and that way we're all speaking the same language, if we will. We are all classifying your vein disease in a very formal way. So here's some examples. Venous eczema. Remember I talked about the itching and rash. This poor patient had spent lots of time trying to figure out what to do about this rash, and it ended up there were varicose veins under here. Remember, small saphenous vein reflux and lots of varicose veins. And once we treated all that, this rash got dramatically better. This poor person has had it go on way too long, and you can see all this red scarring and even whiteness. It's called lipodermatofibrosis, sclerosis. It's really just a scarring from having too much venous blood in the leg. And we talked about the active ulceration, where there's an inflammation that occurs when there's just too much blood sitting in the leg. And because of gravity and these abnormal veins, that venous blood cannot get back to the heart, which is where it needs to go. So what are our treatment options? Well, compression stockings and walking, so that calf muscle is contracting, are very important. They're excellent. And all of our patients need to be wearing compression stockings, and hopefully that can help the treatments. But sometimes that's just not enough. And when that's the case, we use heat, radiofrequency, and laser to close a straight segment of the vein. Or we use non-thermal ablation. It's called Clarivane, or mechanico-chemical, where we use sort of a roto-rooter device with sclerotherapy to close the straight vein. Those little, or not so little, varicose veins, we can also poke and just pull out. And of course, there's sclerotherapy, where we inject a liquid and get the veins to close that way. So let's go through those choices for you. Here's compression stocking. Again, you don't have to wear the full ones. Even to the knee is fabulous, and it's an improvement because of gravity. That's where it's usually the worst. So if you would even wear compression stockings, if you have the problem just to the knee, that would be fabulous. And we like 20 to 30 millimeters of pressure. That's the amount of squeeze, if you will, that we're looking for. If we do radiofrequency ablation or laser, they both work terrifically. They are both heat-related devices. They cause permanent closure well beyond 5 years at over 90%. And they close the long, straight segments. If it's curvy, we can't use them so well. But if they're long and straight for that great saphenous vein or small saphenous vein as an example, they work wonderfully. Here's an example using ultrasound to put our probe into the proper position. We use imaging. That's why radiologists, interventional radiologists, do this technique. We use imaging to make sure our catheters and everything are in great position, and then we can take care of the problem. This is the mechanical chemical, the Clary vein. It's a roto-rooter device that puts in sclerotherapy and denutes the inside lining of the vein, sort of traumatizes the inside lining of the vein, and by using this technique, the vein will close. It's a newer technique, so we know that we're getting the same kind of closure rates at 3 years, but we don't have the longer term data. But it doesn't heat the veins, so sometimes we can go lower, areas where there may be nerves that we don't want to go with the heating devices. We're able to go with a non-heating device and get the closure we want. How about phlebectomy? Here you can see, we just make a small poke, no sutures required, and pull out, as you can see over here, we pull out the veins that are abnormal. And without the blood in them, they can become quite small and come out through very small holes. They look big, but again, it's a very small hole that's required to take out the abnormal vein. And sclerotherapy, we can sometimes use a vein light, sometimes our eye, and sometimes even ultrasound. But what we do is we just inject this liquid in either way. Here there's some air involved, and so these big varicose veins are being closed by our ultrasound-guided probe that's injecting the foam sclerotherapy. But we inject liquid, and we get the veins to close that way. So here's putting it all together, the varicose veins I showed you at the beginning. Here's the drawing. You can see the large great saphenous vein that's refluxing and the small saphenous vein that's refluxing and these large varicose veins everywhere. And here's afterwards with just a couple procedures. Look at the beautiful cosmetic result. But most importantly, and more importantly than the cosmetic improvement, his leg felt fabulous, and no longer did he have the heaviness, the cramping, the itching, and so many of the other symptoms that are present when you have veins like this. And here's the post. And you can see with, again, just very few procedures, his legs felt good, and he no longer was suffering with his superficial venous disease. So now, varicose veins in other areas. Varicocele for a male and pelvic venous congestion for a female. All those things I shared with you, the reflux in abnormal veins. That is the same mechanism as you see with these two entities. And I will go through that now and explain that to you. So the varicocele is abnormal dilated refluxing veins around the testicle within the scrotum. It's usually left-sided, and it can cause a variety of symptoms. Here's some imaging studies that shows you this long vein coming down and producing all the varicosities in the scrotum. We used to like to call it a bag of worms. So when I see a patient with this problem, I'm looking at their legs too, because they go together. And the abnormal veins here can also be associated with abnormal veins in the leg. So 15 to 20% of men can have this. 40% of infertile men, you know, testicles don't like to be kept warm, and the venous blood keeps them warm. In 80 to 90% of the time, it's left-sided, and rarely, more 10%, it's bilateral. Just like with the legs, pain, heaviness, and then the unusual one, infertility. There can be decreased sperm count, motility, and abnormal morphology. So these are the symptoms that can be associated with a varicocele. The treatment is coils and sclerotherapy. I'll show you an example, and our technical success is extremely high. You know, we use compression stockings in the legs, but with the testicles, obviously, compression isn't something most people want to do. Though it is true that when we're doing exercise, when men are doing exercise, if they have a varicocele and they wear more compression shorts, they will feel better than if they do not. So here's an example of an ultrasound, and you can see the dilated abnormal veins off to the left side. Here they are. This is the testicle up here, and these are the abnormal dilated veins in the scrotum. Again, hereditary. We go in with a catheter, and we look at this large gonadal vein, which is refluxing. It is abnormal. And here are the abnormal veins going down into the scrotum. And what do? We just close it off. Similar to the refluxing veins in the leg, where we use heat sclerotherapy to close off veins. Here, we can't use heat, but we are using coils and sclerotherapy to close off these abnormal veins. And here's the example. Here's the coils. And we're also using sclerotherapy in between to close the abnormal vein, and then those varicose veins will shrink up and no longer be a problem. Vaginal varicosities, women who are pregnant in particular that are predisposed, remember your heredity, to having abnormal veins in the legs can have vaginal varicosities as well. So if I see a patient with varicosities, I'm certainly looking at the legs. Now when the pregnancy is done, oftentimes the vaginal varicosities go away, but in some women, unfortunately, they remain. So how do we treat them? Here's the ultrasound. Here are the large black dilated veins in the vaginal region. We use ultrasound and we go in and we inject the sclerotherapy. And with the sclerotherapy, we get these veins to close. You can see with using fluoroscopy here again, we can poke those veins, inject contrast to see where they're going, see what abnormal veins are feeding them, and use sclerotherapy to close them. There's something called pelvic venous congestion, which is basically a lot like the male varicocele. But remember, our ovaries are on the inside, whereas the testicles are on the outside. But you can have abnormal, dilated, refluxing veins around your ovaries, and that can cause pelvic discomfort. So we can go in with ultrasound, just like around the scrotum, just like on the legs, and we can look at the veins around the ovaries and ask you, the patient, to bear down and see if we have reflux in those veins. And if we do, that can be a sign that there is too much venous blood that is causing discomfort in the pelvis. Here's an imaging study as well, and you can see these abnormal dilated veins down in the pelvis. Now, many of us have big dilated veins in our pelvis, and they are not refluxing and they're not causing pain. So we're very cautious with this diagnosis in the pelvis. But that being said, there is a group of women for whom they have abnormal refluxing veins, too much venous blood in the pelvis, and that is the cause of their problem. And like with the men, we treat it the same way. We go into the gonadal vein and we put in sclerotherapy and coils. By closing off that vein, we can decrease the volume in the refluxing veins. Now, sometimes there's also narrowing of a vein that's coming up into the pelvis, the common iliac vein, and if that vein is closed, the pelvic veins can't drain as well. So when we're talking about pelvic venous congestion, we look for reflux in this gonadal vein. We also look for closure and stenosis to a vein along the left side of the pelvis, and we try to make people feel better. So I want to thank you so much for being with us today. I hope we've shared some new information with you and answered some of your questions. We're going to formally answer some of your questions in just a moment or two. As I said, I'm with the Department of Interventional Radiology. There's a whole group of us that treat these entities. So Westwood, Santa Monica, Manhattan Beach, here are the numbers, and we welcome your inquiry. You see us in clinic, we do a physical examination, gather history, and figure out how we can help you. Here's my personal contact information. And I thank you. Thank you. So here's the questions. I began varicose veins when pregnant. How to solve? Well, we'd like to do the full ultrasound and physical exam when you're not pregnant. With each pregnancy, the veins can become worse. So together we figure out what's going on. If you have the problem, when is the best time to treat it? But we don't like to treat it when you're pregnant. We like to treat when you're not pregnant. And then we have to decide if we should wait till you're done with all your pregnancies before we treat it, or should we treat it because it's so bad before your next pregnancy so you don't suffer so much. I have had some patients with really bad leg veins and really bad vaginal veins, and they have to go on bed rest during the last couple months of their pregnancy. Lift things up. Remember, without gravity, the leg veins and the vaginal varicosities will drain. But that's extreme. So that would be someone maybe between pregnancies we would treat. Otherwise, sometimes we like to wait till it's all done, and then we go ahead and treat you and get control of the abnormal veins. Insurance coverage. Most of these procedures are covered by insurance. They're medical. We're talking about the heaviness, the itching, the cramping, the ulceration, the restless legs. All those things really make people not want to move and walk like they need to stay very, very healthy. So insurance companies now, fortunately, are recognizing that, and although, of course, we don't cover deductibles or percentages, it is covered. Outpatient, they're all outpatient. It's sort of like going to the dentist. We like to say we're sometimes better than the dentist. I don't know, it depends where you want to be treated, but it's like that. You know, you can drive yourself to the appointment, drive yourself home, and so it's all done in a very nice, comfortable outpatient setting. How about medications afterwards? I like to have people take a non-steroidal anti-inflammatory medication like Motrin or Mobic, even aspirin, for 10 days. Many of my colleagues don't, but I find there's a phlebitis risk, which means an inflammation to the vein, that I believe is up to 20–22%. But when you take an anti-inflammatory, I've seen our inflammation risk be extremely low, close to 0. So I recommend taking an anti-inflammatory if you can. You know, if you have stomach problems, heart problems, and you can't, it's fine without, but most people can tolerate it. They like it, and that's what I recommend, and that's all. Activity limitations. Well, after most procedures, we ask you to wear a compression stocking to the thigh for 2 days, 48 hours, day and night, and then for 1 week during the daytime only, because remember, we're fighting gravity. So when you're standing up, or sitting down, but during the daytime, we want you wearing the stocking. But when you're laying on the couch at night or laying in bed at night, you don't need to wear the stocking, and that's for 1 week. We also like for 1 week for you to sort of dial it back on the extent of the exercise. I want you walking, I want you doing an elliptical, but not walking up hills or running. You know, just sort of light exercise for a week, and then resume your more strenuous exercise after that. So thank you very much. I hope we've answered your questions, and it's been so nice being with you today. So thank you very much.